The first question people ask me, especially my patients, friends, colleagues, is, how did you get into this? Chronic Lyme, how did you get? And I look at them and I say, you know what? I don't know. That's the honest answer. You know, I was on the road being primary care, family practice, and I would see a lot of patients with these kind of nebulous symptoms, and I just wouldn't know the answer. So a lot of times I would say, that person might need Zoloft, or that person might need psych. And my mom always said I was inquisitive as a child, so I started, you know, maybe I should kind of think outside the box. And when Dr. Shore's job description said for doctors who think outside the box, I checked outside of it. And now I'm here, and I'm a partner, and I'll be here in Lyme for the rest of my life, as Dr. Shore likes to say. So we're going to do this presentation. It's called Lyme, It's Not All in Your Head. And I thought that was an appropriate title because of my history and the fact that I was one of those clinicians who would say that or think that about my patients. And we're going to do an overview. We're going to do the history. I'm going to give you a little information about the local epidemiology, some of the basics about it, making the diagnosis. I'm going to probably make you aware of the legislation, some of the things you probably are already aware of. Give an overview of the clinical presentation and overview of neurologic and treatment. So it seems like a lot, but we'll have fun. All right? So to start, you have to think, does it really exist? And if you can't see the cartoon, the bad news is you have the Lyme disease, but the good thing is I don't believe in Lyme, and you're fine, okay? So the first case of Lyme is 5,300-year-old ice mummy. I didn't know about that, okay, until I started working here. And it said that they may have suffered from Lyme disease because they had genetic evidence of Borrelia and clinical evidence of arthritis. And it was first recognized in the U.S. in Lyme, Connecticut in 1975. It's been recognized all over the world, in Europe, especially in Germany, in the 18th century. And in 1983, the syndromes from both Germany and Europe, as well as the juvenile rheumatoid arthritis cases in Lyme, Connecticut, they saw the recovery of the spiral key. So that's kind of our history. And just looking here, you can see the cases of Lyme disease in our area from 2003 to 2010. So we know it's endemic. And just so you know, the transmitting tick, as you can see here, the adult engorged female can be a lot, well, I don't have a pointer, but you know, you can see the differences in size. And also, if you look at this small bug, that can wreak much havoc. Now, the host could be deer, wild rodents, and other animals. And the whitefoot mouse, that's the preferential host besides human beings. And the things that make Lyme resistant, that it does develop this cyst form. And it kind of makes like a protective coating around of it. And it prevents the disease from being detected in the immune system. And it also has the ability to lower the immune system, which is one of the reasons that we do find that a majority of the Lyme patients are immunocompromised. And with the several co-infections that this is part of this Lyme Borrelia complex, it makes the persistence of this disease more likely. And it's a great imitator, okay? I'm not going to do the laborious task of going through all of these different disorders, but it looks like it mimics all of them, okay? And how do you really make the diagnosis? And if you see there, I'm afraid these tests suggest that you may have a Lyme disease. And that's one of the biggest pet peeves, are people who say L-I-M-E or Lymes, you know. Now, the IDSA, who is the Center for Disease Control, and they set all of the guidelines for infectious diseases. In 2006, they made us aware that in order to have a positive Lyme disease diagnosis. You should live in a Lyme endemic area. You should have a tick bite. You need to have positive serology. You need to have the bullseye RAS, but it has to definitely look like that one, like that one, and that your tick should be attached for about 36 hours. Now this is small, but this is what I was pretty much trained at Brown and at Georgetown, and we went through this algorithm, determine pre-test probability. What does that mean? I never knew. And it was like, did they have a bullseye? And that was the pre-test determined put up probability. And if it was high, then they had Lyme. But then if you weren't quite sure, which was about 20 to 80% of the patients, you should then do the lab work. And if it was negative, it was unlikely. But if it was positive on Western blot, and then they tell us less than 4 weeks after the onset, or 4 weeks or more after onset, they can have IgG and IgM less than 4 weeks, and 4 more weeks IgG only. And then you see negative and positive again, and that's what we were taught. Okay, see how confusing it is. Now, International Lyme and Association Disease Society, of which I'm a member of, we are a group of multidisciplinary physicians all around the world. And we know that Lyme is an epidemic around the world. Lyme exists everywhere. We also know that these tests are flawed and that half of the patients who are actually tested for Lyme disease have false negative results. And we also understand that it's very important as clinicians that we treat these patients based on their clinical presentation and not based on the test results, because as I just stated, those tests are flawed. So there's basically 2 schools of thoughts. It's the us and the them. And the IDSA, they believe the tests are accurate, that CDC surveillance criteria is what we should use for diagnosis. That if they don't get better, doxycycline or amoxicillin, after 10 and 28 days, it's what? All in their head or post-Lyme syndrome. And we also know, I'm gonna restate the point that that's not true, okay? And we also know and understand that CDC criteria was used for surveillance and not treatment. So let's kind of talk about some of the local politics of which my partner, Dr. Samuel Shore, has been very, wave your hand, there you go, very much involved in. The Commonwealth of Virginia, the Governor's National Task Force on Lyme Disease, in 2011 produced a report that responded to the growing number of cases because they saw the trend in this area of Virginians who are affected with these diseases. So Governor Bob McDonough and the Secretary William Hazel, they convened, with numerous other professionals in the area and made recommendations regarding the diagnosis, treatment, prevention, impact on children, as well as public education. And as acknowledged by the CDC, Lyme disease and many related tick-borne illnesses cannot be adequately diagnosed by serology in many cases. And there are no serologic tests that can rule out Lyme disease. And the clinical diagnosis that may be supported by serology remains the proper method of the diagnosis of Lyme disease and related illnesses. So that's huge, and it really stands for the fact that in this region, people are really making a difference in understanding the complexity of this disease and the need for more formal investigation and just accountability by physicians to evaluate their patients for that. And I was very pleased in March when they had the governor sign the law about Lyme disease testing, the Lyme Disease Test Information Disclosure Act, which basically states that a health provider cannot tell their patient that you definitely don't have Lyme disease or that a negative test result does not mean, you have to tell them that your test is negative, but that does not mean you don't have Lyme disease. And that's to take place in July. So a lot of doctors will be going to jail, and I'm one of them, but I think that deserves a round of applause. And of course, Dr. Schroer was very much involved with that as well. So a round of applause, I'm sorry. All right, so let's talk now, an overview of some of the clinical manifestations of Lyme disease. And I don't know if you see that tick there, but the cartoon for those in the back say overall, offhand, I'll say you have Lyme, L-I-M-E disease, but we'll still have to run a few tests to make sure that's true. And as we see, there are several different symptoms associated with this disease. You can have that traditional bullseye rash, of which I am going to show you examples of flu-like symptoms, migrating joint pains, headache, sweat, chills, cardiovascular symptoms, because we know that Lyme can cause heart block, but a little later I'm going to show you other things cardiovascularly that can be associated with this disease. You can also have facial or Bell's palsy, cognitive dysfunction, and severe fatigue. Now, look at all the different rashes, but less than 50% of patients even recall having a rash, and less than 50% of patients even recall having a tick bite, okay? So that's an example of left facial palsy in early Lyme disease. Okay, so now we're going to go a little over some of the evidence-based literature, because as physicians we're always taught, okay, if it's not in the evidence, it's not true. And we know that's not appropriate. At least a lot of us do. But let's talk a little about some of the evidence in regards to chronic Lyme disease. In March 2011, Samuel Shore did a peer-reviewed research where he looked at over 200 patients in our practice who had symptoms of what's called chronic fatigue, which chronic fatigue is 6 months or more of just debilitating fatigue that is not relieved by rest, okay? And that can affect you not only mentally, but physically. And he had a very high clinical suspicion that these patients, even though they were what's called seronegative or had negative testing, had Lyme disease as a part of their clinical presentation. So he empirically treated these patients, and over 88% of the patients got better. And just as a quick overview of what's called the chronic fatigue paradigm that was produced from the research, it just basically shows that we had an understanding that chronic fatigue affected multiple different systems. The mitochondria, so energy, leading to a low energy state. The immune system, and I already alluded to the fact earlier that Lyme has the ability to cause immunodepression. Cardiovascularly, Lyme has the ability to cause what's called dysautonomia, or inappropriate changes in your blood pressure from lying to standing. And that's because, someone said, oh, there you go. And that's because of its effect on the autonomic nervous system, okay? And that's the part of the nervous system that's responsible for either that what's called fight or flight, so when you get scared, that's the sympathetic, or when you relax, that's the parasympathetic. So that's the system that can be dysfunctional in Lyme disease, where you have disorders. You may have heard terms POTS or orthostatic intolerance. Those all classify under autonomic dysfunction. You can also have abnormal neurologic symptoms. And being that I was a neuroscience major, they made me pay a lot of money to just learn about this system. So it took me 4 years and a lot of books, and you know what? It's really straightforward. You have two nervous systems. You have the brain and the spinal cord, which is central, and then everything else. that's peripheral. So I felt like I kind of probably wasted a lot of time when there are only two nervous systems, and Lyme can affect both of them. Patients can also have pain, which is associated with fibromyalgia, sleep, the endocrine system, which is the system that's responsible for hormone balance and regularity, and there's also a psychiatric component. So this is just another overview. I'm going to kind of breeze through this slide about the nervous system. And like I alluded to, you only have two, the central and the peripheral, and that this red is this autonomic nervous system, which regulates just about everything in the body, and the somatic, which does the skeletal muscles. And we talked a little bit about how Lyme can cause an adverse reaction in both. Now, cognitive. A lot of patients do present with what's called brain fog or cognitive impairment. And I know over time and, practice previous to being exposed to chronic Lyme, patients have cognitive dysfunction and they might need Zoloft again, right? And they have processing difficulty, organization difficulty, problems with memory. You can also have associations of mood instability. And one of the things that I find fascinating about this disease is that with the process, you do relieve what's called toxins or cytokines that leads to inflammation. And that inflammation or toxin reaction can lead to the development of a very neurotoxin acid there. And that's going to decrease the production of serotonin. So I'm sure you probably heard the word serotonin associated with depression, mood instability. And that problem can lead to the mood disorders, can lead to the impulsive symptoms, the obsessiveness, the paranoia. And now we're going to end by talking about some of the diseases, the degenerative brain diseases that Lyme can mimic. The same plaques that were found to be abnormal in Alzheimer's were also present in Lyme disease patients. Also with multiple sclerosis, over 18 publications, because they said that Lyme destroys what's called the myelin, which protects our nerves, and it attacks it. And in that process, you get the complications of multiple sclerosis, which is secondary to the exposed fiber, and that happens secondary to the Borrelia attack, okay? So that's the same thing that happens in multiple sclerosis. And ALS, or Lou Gehrig's, which is a disease that shows problems with both upper and lower neurons. Patients have muscle weakness, paresthesis, which is kind of numbness, tingling. And they showed in this paper, which I thought was fascinating, that 3 out of 24 patients diagnosed with ALS improved with IV Rocephin, which actually treats Lyme disease, okay? So
Is it an antibiotic?
Rocephin, yes, that's an antibiotic that treats Lyme disease. And I've actually, probably every Lyme specialist here in the world has seen patients like this who come to us with other diagnoses and had a Lyme component to their clinical manifestation. I actually have anecdotal evidence of a patient who had this ALS presentation and also improved with parenterals. And how did we treat this? Okay, and we know that this is definitely a chronic illness, and unfortunately, there's no cure. And remember earlier, I told you about how complex this disease is. And it also you want to get remission, okay? And I tell all of my patients that this is a chronic disease. It definitely has a waxing, waning course, but our goal is to gain remission and to keep you there. Now, some of the possible adverse effects of Lyme treatment is what's called the Herxheimer reaction, which a lot of patients say, well, I feel worse before you feel better. And it's just secondary to all of these kind of toxins that are released in your body when you kill bacteria, okay? And those toxins can just exacerbate Lyme symptoms, neurological symptoms, musculoskeletal symptoms. And then if you think in regards to the nervous system, I stated earlier that there is a psychiatric component. So a lot of patients can have worsening of their underlying psychiatric disease. So that's always why we should address that. We have publications that show that that's definitely evident, and we know that patients can have what's called Lyme rage, where they're angry out of nowhere, and it's not just out of nowhere, it's secondary to this underlying infectious process, or worsening depression, suicidality, more violence. And it's not that it's separate. That's kind of the misconception. It's all together, and that's one of the reasons why we collaborate so much at my practice with the Amen Clinic, because we have that baseline understanding. And also remember, detoxification is very, very important before you start any treatment. And you want to make sure you start slowly and you monitor closely. And we try to start like just with kind of a comprehensive, holistic approach. You do your initial screening, you know, making sure you rule out biotoxicity or exposure to different things in the environment, or just overall production of toxin. That can be with our questionnaires. Make sure you kind of evaluate and interview regarding possible heavy metal exposure. Make sure you start herbals and get patients in regimens that can help their body detox, like anti-inflammatories, liver, kidney, lymphatic detoxification, what's called free radical scavengers, which are agents like glutathione that can kind of bind the toxins in the body, vitamins, okay? But sleep is very, very, very important, because if your body's not resting, your body's not healing, okay, you're gonna be tired. So we need restorative sleep and feel refreshed in the morning. So to do that, to achieve that, you have to really evaluate, well, why is this patient having fractured sleep? So you gotta make sure you look at the pain, make sure you assess the sleep hygiene, make sure you assess the mood, try to reduce stress, improve the mood, decrease anxiety, and make sure in your evaluations and interview that you evaluate for sleep apnea, because we see that a lot. And you want to really make sure you also treat the gut, because 60 to 80% of the immune system activity in humans focus in the GI tract. So you want to kind of try to remove unhealthy bacteria. Some patients, and mind you, this isn't standard for every patient. These are just things you want to make sure you think about as a clinician, and as a patient, also things to think about. But you want to make sure you remove unhealthy bacteria. In our practice, when we have patients that we're concerned have GI complications, we will do a test that's a stool test to look for yeast overgrowth, bacteria overgrowth, parasite. You want to make sure there's a good probiotic on board, that the bowels are moving and functioning. I just told you this disease causes what? Toxin production. So you want to remove those toxins. And removing toxins from food, okay? Making sure food allergens have been evaluated, making sure you look and evaluate the nutritional deficiencies. Then you think about, okay, let's treat the underlying infection. Now, there are no guidelines regarding the duration of Lyme treatment. We just don't have firm guidelines at all, okay? We treat based on your clinical diagnosis, and it's really based on a physician's clinical judgment. And like I alluded to earlier, there are co-infections that need to be addressed. Some of the treatments includes antibiotic protocol, herbals. There are also alternative forms of treatment, hyperbaric oxygen treatment, which is something we use at our practice. And you also want to make sure you reduce the stress on the body by doing the pain control either with medications or physical therapy, holistic approaches, acupuncture, massage therapy, lymphatic drainage, Epsom salt baths just to sweat. Saunas can be helpful in some patients. Some patients find a lot of benefit from craniosacral massages. Make sure you treat and evaluate the endocrine system, which is responsible for metabolism. So thyroid level, cortisol level. Make sure you strengthen the immune system and improve the mood and stability. And I like to look at it at coping with the double L's, life and Lyme. Recognize your symptoms, find those supportive people, family and friends. Make sure you prevent ticks. This is that time of year. So if you don't know about tick prevention, this is the time to learn. You can ask me afterwards, I'll be here. But more importantly, spraying or finding a DEET product to protect yourself. Find yourself a Lyme literate or even a Lyme sensitive physician. And really encourage someone else. I hope you all leave here today. We do have a great panel with just some information to share with family and friends. There are organizations like ILACS, like NatCat Lyme. And just stay optimistic. This disease is complicated. It does affect numerous different systems. It is challenging. It does wax and wane. But it's a good power to have that good spirit about it as you go forward with this fight, because it can be hard. That's why it's important to have that support. And losing is not an option. You gotta remember that as you go through and go forward. Thank you. I have also on the table outside. Sorry.
I actually have a couple questions. One is, do you happen to have a copy of the PowerPoint?
I do have one. If interested, it's on the computer here. I'll provide it to you as well, or I don't know if I can give it through the Amen.
Well, yeah, maybe you can
Larry, the email address.
That'd be awesome.
Give it to you.
Okay.
To who should they give the email address, Larry? To you or?
Yeah, just
or leave it.
Can you just email it to everyone who signed up with their email?
Right, just need to email. That would be great.
Yeah.
That would be awesome.
Thank you. And we all want it.
You can have it.
The other couple questions I have. One is do you know a specific best test to take if someone's showing symptoms and they're not sure if they have it? I mean, obviously Western blot, a lot of false negative. I've heard CD57, C4A. Are those the two you would recommend? Is there another?
Yeah, IGeneX is a laboratory that is more sensitive than the Western blot that we find from LabCorp.
So isn't IGeneX a lab, not a test?
That's a lab test. They do Western blots for not only Lyme, but all of the co-infections as well. That's a more sensitive test. It's out in California. They also have cultures, and they have additional tests on the horizon. One of the cultures is from Advanced Labs. They have cultures that you could, that are available. But still remember, and CD57 is a good test to give underlying information about the immune system. CD57 represents what's called natural killer cells, are cells that naturally fight off infection, and it's found to be low in a lot of Lyme patients. So, but remember, those tests may not be positive, but they're out there and they're available.
There's one other question. What does your practice do?
My practice, we're Lyme specialists. We work with chronic Lyme, chronic fatigue, fibromyalgia patients.
So would you be in lieu of, instead of an LMD, or you work in concert?
No, I am a LMD.
Oh,
I am
okay.
a Lyme literate physician.
Okay.
Yeah, so yeah, that's what we are. That's what I am, and we also.
That's all you do.
Right.
Yeah.
We do. That's the majority of
Okay.
what we do, and we also have our hyperbaric center. So I am a Lyme literate
Can you
physician.
hear me, Russ?
I am here with Breston. I do have my card outside. We are taking new patients if interested. Oh, that was your question.
Yeah.
Yeah.
And I'm our publicist. So
Yeah, and we're growing. We're a growing practice. It's myself. We have another nurse practitioner and bringing on another associate. So we will be taking new
Do
patients.
you take insurance? or-
We do not take insurance. We're not affiliated with insurance. Yeah, thank you.
You know, I don't know how sick people are that are here, but I have an unbelievable version of Lyme that I think is going to kill me. And I have Lyme literate doctors, and we've been gone all through this. So basically, my disease started in 1976, and it exploded in 2005. I have multiple exposures. And my question now is, well, this stuff is really difficult and confusing. And now as my Lyme continues, my brain capacity is becoming less and less.
Yeah.
I can't manage this.
Yeah.
I literally cannot manage it.
Yeah.
Where does one go? I mean, right now, I had comprehensive care at the beginning, which was very useful. And now, because it's so bad, I'm out in the world with all of these specialists, and I can't teach them about this. Where do you send doctors to get the information that you just gave in 5 minutes so that they can have some clue that we're not making symptoms up for? I mean, where's that way?
And if I could answer that question, I would be the best person in America. I wish I could, but we send them to ILADS, and it takes people like you to keep advocating. That's why we have these laws that are being passed. But one of the best websites, www.ilads.com, is very helpful. But physicians, we have to have those that are open. But I've been surprised about a lot of the physicians who are now becoming Lyme sensitive. I collaborate with quite a few physicians in this area, and it seems that hopefully there's becoming a trend, I hope, to learn more about this among the health community. And I think especially starting with this new legislation, it's going to be imperative, because even with those, if you have, specialists in Virginia, they're going to have accountability. So it's important that we realize that this is a process and evolution, and we stay committed to advocacy and teaching, but it's just going to take us reaching out.
It's interesting you mention that, because I come from Maryland, and I think I'm the first person in Maryland to get disability for Lyme. Wow. And that happened in 2006.
Yeah.
So that was pretty early. So I was shocked because my doctor didn't want to write Lyme. And I was like, but that's what's killing me.
Yeah.
It's crazy not to write it. But it is happening, but might not be fast enough for some of us.
Definitely. Okay. So, like I stated earlier, I learned that exam in college, being a neuroscience major, and it's based on the evidence. Like I stated earlier, as doctors, we need the evidence. But we have to remember who provides it. And also, if you think about it, as a physician, we want to know the direct answer. Yes, no. Things should be black and white. But when you have a disease like Lyme with so many shades of gray and so many nebulous symptoms, it's really difficult for that evidence-based test to assess that patient. So I think the answer for you is, the reason why there's so many abnormal neurological testing results is because that test is standardized, and the symptoms of Lyme disease, they're not. So it won't really be relevant in a lot of patients' cases, or interpreted, appropriately by the physicians. Regarding following up and teaching others, another thing I always tell my patients is get your arsenal, get the literature that you need, ask me the questions that you need. And one of the other questions we ask our patients when on initial meeting, who do you want us to send this to? Is there anyone you want us to send us to? Because we provide literature when we submit, our evaluations to other doctors. We always welcome the idea of collaborating or just teaching. I don't know how many doctors I've sent notes to or had reach out to me, and it's hard. It's going to take time, but it's happening.